Hi, I'm Andreas. I'm working in a cardiology department in Vienna, Austria, and I'm happy to present to you the next chapter, and that's pulmonary hypertension and right heart disease. But before we focus on that, let's widen our perspective a bit and have a look at various diseases affecting the right ventricle. In some cases, like chronic thromboembolies, as you can appreciate in this huge thrombus that has been surgically removed from the pulmonary artery, or in this ASD type 2, the impact on the right heart is pretty obvious. In other conditions, like drugs, hemolytic anemia, HIV infection, smoking-induced COPD, or liver cirrhosis, the influence on the right heart is not that obvious at the first glance. But they do have one thing in common. All of them can cause pulmonary hypertension. So what's the definition of pulmonary hypertension? Well, it's defined as an increase of mean pulmonary arterial pressure equal more than 25 millimeters of mercury at rest. This is usually assessed invasively by right heart catheterization. Normal values range between 11 and 17 with an upper limit of normal of 20 millimeters of mercury. The significance of values between 21 and 24 is still unclear. After the first clinical classification was proposed in 1973, the Evian Venice classification suggested 5 groups, according to pathological, pathophysiological, and therapeutic characteristics. Finally, maintaining this philosophy and organization, a consensus agreement was published in 2008 during the 4th World Symposium on pH held in Dana Point, California. This table provides an excellent overview of disorders leading to pH. When I first saw this long list, I was pretty impressed, as I never thought of so many causes of elevated pulmonary arterial pressure. So let me guide you through this busy slide. We mainly distinguish 5 groups: diseases affecting the distal pulmonary arteries, the so-called pulmonary arterial hypertension, or PAH, which comprises idiopathic or heritable disorders, as well as drug-induced and toxin-induced ones. Pulmonary arterial hypertension can be furthermore associated with connective tissue disease, like systemic sclerosis, with HIV infection, portal hypertension, congenital heart disease, and chronic hemolytic anemia. You have seen pictures of those in the beginning of the presentation. Parasitic disorders are certainly of major concern in some countries, but very rare in my own country. The second group contains diseases affecting primarily the left side of the heart, like systolic or diastolic dysfunction or valvular disease. The third group contains disorders affecting primarily the lungs, like chronic obstructive pulmonary disease, interstitial lung disease, or chronic exposure to high altitude. Chronic thromboembolic disease is the fourth group, and last but not least, the fifth group, containing disorders with unclear or multifactorial mechanisms, such as myeloproliferative disorders, sarcoidosis, or thyroid disorders, and many, many others, some of which I've actually never seen before in clinical practice. Once again, let's summarize the 5 main categories: pulmonary arterial hypertension, left heart disease, lung disease, chronic thromboembolic disease, and others. Interested in some epidemiological data? Well, a survey performed in an echo lab showed that the prevalence of PH came up to 10.5%, so it's not a rare disease. By far the most common cause is left heart disease, with 78%, followed by lung disease with 10%. So taking those two together, you will identify almost 90% of causes of pulmonary hypertension. Pulmonary arterial hypertension accounts for 4%, and chronic thromboembolic disease you will find in 1%, whereas 7% of the cases remain multifactorial or unknown in their etiology. The prevalence of pulmonary hypertension in patients with chronic heart failure increases with the progression of functional class impairment. Up to 60 to 70% of patients with severely reduced left ventricular function, as you can see in this patient, or in isolated diastolic dysfunction, may present with pulmonary hypertension. In left-sided valvular diseases, the prevalence of pulmonary hypertension increases with the severity of the defect and of the symptoms. Virtually all patients with severe symptomatic mitral valve disease, as you can see in this patient with severe mitral regurgitation, and up to 65% of those with symptomatic aortic stenosis will have pulmonary hypertension. Hemodynamic definitions. Well, don't worry, it's not going to be complicated, but let's have a quick look at hemodynamics, especially at a pulmonary wedge pressure, and see whether it can help us to distinguish between the two major forms of pulmonary hypertension, the pre- and the post-capillary form. Well, if you get values over 15, then left heart disease is very likely to be the cause of pulmonary hypertension. On the other hand, if you get values under 15, then look for other causes of pulmonary hypertension, like lung disease and chronic thromboembolic disease. The question really is how to assess pulmonary wedge pressure, and you certainly know that you can do it invasively by right heart catheterization, but you can also use echo. And I've shown you, for example, this formula on the right side that gives you an estimate of the wedge pressure using Doppler measurements like E3 prime, multiplying it by 1.24 and adding it to 1.9. While other methods, newer techniques like strain or strain rate, are supposed to help you and give you an estimate as well. The second most common cause of pulmonary hypertension is lung disease, and it's actually not really rare. If you look at the incidence of significant pulmonary hypertension in patients with advanced COPD, well, it's more than 50%, and it's even up to 40% in patients with interstitial lung disease. Do you remember the picture I've shown you in the beginning of the presentation? Well, let me show it to you once again because it's really impressive. This huge thrombus was removed surgically from the pulmonary arteries in a patient with chronic thromboembolic disease. And it's really amazing how much thrombotic material can accumulate in the pulmonary arteries. And if we're lucky, we can even visualize it on its way to the lungs. As you can see in this patient, we managed to get the embolus stuck in the right ventricle. The diagnosis is usually confirmed by CT scanning, so have a look at the CT scan on the right side. The arrow indicates contrast sparing, reflecting a huge thrombus that got stuck in the pulmonary artery of this patient. On the left side you can see a pulmonary angiogram that's nowadays only rarely performed to make the diagnosis, but it's pretty impressive as in this case because it shows a huge perfusion dropout of almost half of the lung. Well, you've probably noticed that the pictures are not from the same patient, but should give you an idea of different methods diagnosing pulmonary embolism. Did you actually know that only 0.5 to 2% of patients with an acute pulmonary embolism develop persistent pulmonary hypertension? Well, we don't have accurate data on that, but that's what experts believe. And the risk of developing persistent pulmonary hypertension is increased with an SPAP of over 50 millimeters of mercury at presentation and failure to normalize within 1 month after diagnosis. Never forget that an acute pulmonary embolism is a potentially life-threatening condition. So it's really crucial to prevent further events. And we are doing so in everyday clinical practice by putting patients at risk on an oral anticoagulant like warfarin, but in certain cases we can also consider special protection devices that are implanted in the inferior vena cava and can protect from recurrent episodes. Do you still remember the classification of pulmonary hypertension? Well, here's group number 5, and that was the group with unknown or multifactorial etiology. And it comprises actually a long list of different conditions, like for example sarcoidosis, as you can appreciate on the chest x-ray on the right side, with bihilar lymphadenopathy or chronic renal failure, and so on and so on. But actually, don't want to stress too much on that group. The so-called pulmonary arterial hypertension group, and that's group number 1. It accounts for about 4% of cases of pulmonary hypertension, and recent data have confirmed that the prevalence is in the range of 15 to 50 subjects per million population in Europe. It comprises actually heterogeneous conditions that share comparable clinical and hemodynamic pictures and virtually identical pathological changes. So what are those pathological changes that they all have in common? Well, it's actually changes of lung microcirculation, progressing from early medial hypertrophy to end-stage plexiform fibrosis, leading to an increase in pulmonary arterial pressure. When it occurs in a familial context, germline mutations in the bone morphogenetic protein receptor 2 gene are detected in at least 70% of cases. But it also occurs sporadically after drugs like amphetamines or fenfluramine, which used to be taken as an anti-obesity medication. And pulmonary arterial hypertension can be further associated with different diseases like connective tissue diseases. Remember, systemic sclerosis is one of them, or HIV infection, portal hypertension, or chronic hemolytic anemia. Congenital heart disease can be associated with pulmonary arterial hypertension as well. An echo is certainly the method of choice to investigate for those and identify systemic to pulmonary shunt lesions. So have a look at the study on the left side. In this patient, you can see a huge ASD type 2. On the right side, you can see a patient with a ventricular septum defect. Well, we have been talking now about pathologies of the small vessels of the lung, and we have been talking about different causes of pulmonary hypertension. But did you actually know who discovered pulmonary circulation? Well, you can see him on the left side. It was Ibn al-Nafis. He was born in Damascus, and he discovered pulmonary circulation in 1213. And he was the first to understand the function of the right heart, the function of the pulmonary artery and veins, and thereby proving the theory of Galen wrong, who assumed invisible pores in the septum to the left side of the heart, where he thought that the blood mixes with air to create spirit. Back from history to recent data from registries, associated diseases account for a bit more than 50%. In these conditions, you will usually find presenting symptoms of the underlying disorder. Unfortunately, that's not the case in the idiopathic and heritable group. And as they account for about 43%, it's really crucial to identify them very early, especially as prognosis worsens dramatically with an increase in the clinical WHO class. And have a look at the diagram on the left side. Patients in WHO class 4 have almost the same prognosis like patients with advanced lung cancer. And that's pretty shocking. So what we have to do is identify those patients at an early stable phase to prevent this rapid decline and deterioration. But how can we do that? Well, unfortunately, symptoms are not specific at all. patients can present with an insidious onset of shortness of breath, they can have chest pain, syncope, peripheral edema and so on. All of those can be due to other diseases as well, and therefore diagnosis is often delayed. So we have to look for the right screening tool. Well, so let's find out whether the ECG and chest X-ray can help us out. They're both widely available and certainly not expensive investigations. Right ventricular hypertrophy on ECG is present in about 87% and right axis deviation in 79% of patients with idiopathic pulmonary arterial hypertension. Unfortunately, the absence of these findings does not exclude the presence of significant pulmonary hypertension, and so ECG is unfortunately an insufficient screening tool. So let's have a look at the chest X-ray, and first want to show you the typical findings you can expect. And that's first of all dilatation of the central pulmonary arteries, which contrasts with loss of the peripheral blood vessels. Well, it has been shown that chest X-ray is not a perfect screening tool as well, but it's very helpful excluding lung diseases and left heart disease. The ideal screening tool is echo, and in a survey performed in an echo lab, out of 4,579 patients, 11% could be identified suffering from pulmonary hypertension, taking an ASPAP of over 40 millimeters of mercury as a cutoff value. And if we look at the recommendations of the European Society of Cardiology, we will find that echo plays a central role in the diagnosis of pulmonary hypertension, and a class of recommendations 1 and 2A. And if you have a closer look at that table, you'll find different echo-derived measurements helping you in the diagnosis of pulmonary hypertension, making pulmonary hypertension unlikely, possible, or likely. I'm sure that now you've heard enough about echo statistics, definition and recommendations, and you're already keen for some echo loops. And that's exactly what we're going to show you in Chapter 2. So hang on and get familiar with the pearls and pitfalls of assessing pulmonary hypertension with echo.